So for those of you who don't know me, I'm Mel Hall and I am Head of Service for Primary and Community Mental Health. And I've been with Primary Care Sheffield for just over 2 years now. And as part of the work, we've been looking at how we make what was a early implementation of multidisciplinary teams within primary care networks. How do we make that sustainable? And how do we ensure that we have an offer that meets people's needs? Yes, Kate, you already have it in Foundry. So please feel free to use the chat, and I'll try and remember at maybe 1:45 is to just jump back into the chat and make sure that if people have got specific questions that they're being answered. So I'm going to go through a quick PowerPoint, and the PowerPoint will describe to you what we're trying to achieve and what the operating model looks like. So if I share my screen, and again, if you have any questions, feel free to put your hand up and I'll come to you once I've done the PowerPoint. And once I press play, I won't be able to see anybody. So that's a bit about me in a very glamorous photo. I don't look like that today, unfortunately, but so this is me, Head of Service for Primary and Community Mental Health. This first slide talks about the rationale, why have we got primary and community mental health? So we're an early implementer, and we've built up the model from primary care that's using the additional roles, which is part of the work, and bringing it together so that we can provide a mental health service that works across 15 primary care networks, which is around 600,000 people in the city. And we know that it's a mix of urban, and we know it's a mix of rural, highly affluent, and then some of the lowest affluence in the city. And historically, SMI has been seen in mental health, has been seen as the mental health trust's business, and there's been little in the way of a two-way conversation between primary care and the secondary care provider. But we're set to change, and we have been learning how we can do things differently. So this slide that we have in front of us is around who are the right people into which parts of the system. And in the first, which is quite a mustardy colour on my slide, talks about those patients that have got distress. So there are low levels of distress, people that have got issues around their housing, social potential issues, work, home life. And that's where we find that the additional roles through social prescribing, for example, can support mental health, emotional wellbeing service. I think we've got in Foundry, and we've got other aspects which are more lower level, but still really important around prevention for mental health. Those people got physical health and mental health needs. But we generally see a lot of the voluntary sector in that space. The next is around common mental health problems. So these are the anxiety disorder and depressions, and those that were seen in IAPT, which has changed its word name to talking therapies. And talking therapies is specifically around talking therapy. So it's very much from a model of therapeutic treatments, and it works around long-term conditions and pathways. The next is your severe and enduring mental health problems, so SMI. So this is crucial, that people that we see within primary and community mental health have got serious mental health problems. And those are people that are too complex for talking therapies, but not risky enough for secondary care or traditional secondary care models. And what we see in this space here is around that integration of primary and community mental health. And these lines that you see between core, specialists and support from PCNs in Sheffield, we are blurring that first line around what is primary and community, what can we offer people that have got a serious mental illness that needs a different offer to therapies, but something that we can be practically helping people to remain in the community and remain well. We treat mental SMI symptoms. It is not a diagnostic service at this point. And in the far end of the scale, we see the crisis response and community and acute care. And again, primary and community are a 4-week planned service. So what does that look like for us? So to build a model that makes sense for Sheffield, this, what could look quite a busy slide, tries to describe each primary care network. So in each primary care network, the remote booking provides a number of slots for patients. What we found over the last 3 years is that if we only use the information that is sent to us by a referral, or if we're looking in patients' notes, it's very deficit based. We don't gather out what are the strengths of the patients, and we don't understand what their expectations are either. And sadly, we still have occasion when patients are not even aware that they've been referred through to mental health or into our service. So the screening appointments are a phone call, which I will describe in a moment, but they're there to understand the expectations, the triage in effect of who needs urgent crisis standard is set by the GPs. So patients are booked directly into those screening appointments. We don't expect GPs or clinicians within primary care to understand the differences or do the treatment planning around occupational therapy or community connector, or whether it needs a mental health wellbeing practitioner or a CAP. We recognise that those kind of complexities is something that we work through with our MDT. And whilst they will come into your practices and there to ask, you can ask them as many questions you like. When we start treatment planning, we recognise that it needs to be through screening. What we have learned over the last 3 years, though, is that you guys know a lot about pharmacy and when you need extra support around mental health pharmacy. So as a result, we have responded that a referral is not needed through a screening, but a direct email can be sent from you as a practitioner to the primary community pharmacy team, just done through our administrators. And they will then look at the note and provide either advice to you guys about prescribing, or they will invite a patient in. And that's something that we've worked on over the last few, certainly in the last few months. So in this screening, you'll see that the future, we've got an orange section which says Trusted Assessor SHSC. And this is because in the future, as we bring the Emotional Wellbeing Service, which is part of SHSC, into the primary care network level response, they need to be able to make referrals in. Now, the demand, which you can see, the proportion is more from primary care than it is from SHSC. But what we are having is the staff coming in April from SHSC to support their proportion of work. I'll pick this up, I'm showing questions in a bit. So this is a very broad overview about how the process works and where the remote booking is seen as the result, as the way in which to get into services. Lastly, at the bottom, Step Core and Step Neighbourhoods, the orange section at the bottom. This is an offer that is currently citywide, which will be also brought down to primary care network level. So it may be in your network, there's a specific group of patients that you feel that have got a serious mental illness that need some group work or some specific education. The message doesn't change, but how we deliver it may. So it may be, for example, we do it in another language, or we do it at a time of day or in a place that meets the population need, which currently they feel they've got barriers to. The second part, the other part on here worth highlighting is around huddles. There's quite a lot of work going on at the moment around what does a huddle look like. The purpose of a huddle is to reduce what you're currently experiencing at the moment, which is lots of pushback here, there and everywhere, whether it's from talking therapies and being asked to come to PCMH, whether it's from SPA or from early intervention or site liaison. The idea is to bring these huddles together so that as the GP and practice, you're not kept in the middle of it. But this is what we're working up at the moment. So this next slide, and it's my last slide, talks to you about how it works for the screening appointments. So once a patient is booked into our system, into the slot, we speak to that patient to gather more information. So we're screening what their expectations are. They're remotely booked by practice. There's a 15-minute slot before the patient appointment where the clinician can look at the IAPTIS, the GP notes, looking at Insight and what would be Rio. And that's so that we get a bit of a history before we speak to the patient. This means that you don't have to do lengthy referral requests into the team, but it's helpful to have it on the system, what we're trying to draw out. We also send out a dialogue scale to the patient. That could be either by email, text, or by letter, generally by text message. This helps the patient think about what are the key areas that they want to address in their mental health offer, and it helps the clinician to prepare. It also means at the end of the sessions, when we finish with the patient, that we can demonstrate that what outcome's been achieved, both to the patient, but also for you guys as well. Is then a phone call, and it's a 30-minute conversation with the patient to discuss expectations, what might happen next, what can be achieved. It can be done as a face-to-face appointment if we're given enough notice. So when it's booked in, the 2 weeks beforehand, if you let admin know that that appointment needs to be face-to-face, we will make measures to make sure that we do that. And the same if a translator needs to be booked. We then will either give the patient some self-care whilst they're waiting to see us, but we may also say that we will also book them in a treatment appointment as well. If the patient doesn't want to join the doesn't want the service, or if we identify with the patient that this isn't quite the right offer for them, we will let them know, and we'll also let you guys know as well. So next we plan the treatment. So this is when we start getting into the model, and we do that based on an assessed need. The mental health, we identify with the patient what their needs are for treatment and the intervention that we'll provide. It may be that more than one patient, one clinician is working with a patient at any one time, because it's quite not unusual for a mental health practitioner to be working with a patient around self-harm reduction as well, and building confidence, as well as a community connector joining a local group. We complete the risk assessment, and we also complete crisis plans with the patients. We complete baseline scores, so a bit like when you start any kind of treatment, we have to work out where we're at before we start providing the intervention, and we talk about what the shared goals will be. We agree with the patient at that time what the number of sessions are going to be and the frequency. Typically, frequency is weekly, but sometimes it's fortnightly. And those sessions are based on an evidence-based provision that's within that profession's background. So, for example, if it's with a mental health nurse, then it'll be using a nursing emphasis. If it's a mental health occupational therapist, occupational therapy approach. And if the person needs something more specifically around, say, for therapies or for occupational therapy, maybe they have to wait whilst they're in our service. And we have a waiting list process, and we risk assess whilst they're waiting, and it's reviewed every 12 weeks. So then we start the treatment, and that is booked and managed through the PCMH administrators. So once they come through, we will pick up all the bookings around appointments and send out reminders. Appointments are usually face-to-face or virtual, sometimes in a group one-to-one, mainly one-to-one, but sometimes in group as well. All notes are visible via GP Connect, and that's including for your EMIS and direct on System 1, because that's the operating model that we use. We again complete a recall measure halfway through treatment to see that it's taking effect. And then finally, we come to the end of treatment. So treatment is completed. There's notes and summaries are always on the system. We review with the patient their treatment goals and their outcome measures and a risk plan. We are never going to always remove all risk within a patient, but it's about understanding what influences those risks that's important. And then it's remembering, because we have a treatment model and it flows through, that a patient can come back into the system. We typically would ask that it waits around 6 months, because we expect patients to start using the skills that they have and consolidating. But we can always, but we will go with whatever the practice makes the decision on. And that's how the model is delivered. Harrison, do you want to just turn your camera and say hello, and maybe give a little bit of a overview?
Hi everyone. We might have spoken emails, or you might have might have spoken in the past. My name's Harrison. I work here at PCS as a clinical system specialist. So if there is kind of any elements of kind of anything we spoke about today in terms of how to actually navigate or how to kind of actually complete the remote bookings, you can feel free to get into contact with me. I'll put my email address in the chat, and we can can we walk through that together. I'm sure most of you are probably familiar with kind of remote bookings and doing that in the past, but if I just popped a little message in the chat about just making that a little bit more streamlined. If you are using System 1, you can use some of the quick link buttons and things like that to make it a little bit quicker to navigate to. But if you do have any kind of technical questions, you can always reach out to myself, and I'm more than happy to hop on a Teams call and go through those with you.
Thanks, Harrison. And for those of you I didn't introduce, so Jules is my ops manager, everything sort of ledger based, and she does all the pulling of the information once it's been set up by Harrison. So Harrison and Jules are my dynamic duo. So if you do have any further queries, they generally will have the answers. If we're needing something a little more dynamic within your PCN, if there's something that you specifically think it could be good if, I'm more than happy to sit and test what I can with you. And yeah, let's see what's possible. But as I mentioned, we're moving to this process for all bookings into PCMH for treatment to be starting in the new year. And each network will have the slots put on the system.